Okay, so here's the agenda, kind of some of the things that we're going to hit. We'll hit normal anatomy changes, normal physiology changes, and then we'll start to go into some of the pathology. Trauma, which obviously is a big component of what you guys learn, but also the most common or most severe complications of pregnancy. Okay, so first we'll go through some of the anatomic changes. Most of these are due to the change in hormones that happens throughout pregnancy. So we see skin changes. These can be on the abdomen, the linea, melasma on the face. We also see changes in the collagen and connective tissue throughout the body, so you get loosening of the ligaments and tendons throughout. Most of the time we see these predominantly within the pelvis to make room for birth, but these can happen anywhere throughout the body. So you'll see women get joint laxity all throughout pregnancy. The uterus grows in size anywhere from 12 to 24 pounds, depending on baby's weight, weight of the muscle of the uterus, the placenta, extra blood flow that we accumulate through blood volume during the pregnancy. And that obviously puts pressure on surrounding organs. So you can see a couple of scans here showing the growing uterus putting pressure on the rectum. It puts pressure on the bladder, the muscles, and bones of the pelvic floor. Blood volume can increase by as much as 50% in pregnancy, and most of that happens actually early on in pregnancy. And then cardiac output also increases by about 15% as we go through the pregnancy. Okay, so this graphic up here is just showing change in respiratory physiology throughout pregnancy. So as the uterus grows, that pushes up on the diaphragm. So women will have a relative feeling of shortness of breath. It's not a panting, increased respiratory rate so much as they don't feel like they can get that big deep breath. The diaphragm can't push down as much. And so in order to maintain normal respiratory physiology, then their resting respiratory rate goes up, right? They also get increased pressure as the uterus grows on their stomach, their esophagus, so they get a lot of increased acid production as well, so that comes in with the heartburn and acid reflux that goes along with pregnancy. So this is showing some of the vital sign changes. We already talked about cardiac output increases by as much as 50%. Heart rate also increases, and that happens a little bit each trimester. So you get a little bit increase in heart rate in the first trimester, a little bit in the second trimester, the most in the third trimester. So normal resting heart rate in the low 110s can be normal in a term pregnancy. Oxygen consumption also increases by 20 to 40%, and that helps with offload of oxygen from mom's bloodstream into babies. And then this increased demand is met by increased cardiac output as well as increased overall tidal volume. So we talked about how mom's oxygen consumption increases. In order to offload that oxygen to baby, her relative CO2 goes down as well. So as you can imagine, when people hyperventilate, right, they blow off more. Mom does that a little bit too. So her PCO2 is lower than babies. Okay, any questions about normal anatomy or physiology changes? I know I kind of blew through that, but a lot of that is just kind of standard in your reading. Okay. So let's talk about trauma in pregnancy. So trauma is something that we really start to become worried about in the second and third trimesters. First trimester trauma is not as big of a deal because the uterus is still very well protected within the pelvic bone structure, okay? So after about 12 weeks gestation, that's when the uterus starts to grow into the abdomen, and that's when it's more at risk. So obviously the two most common sources of trauma are going to be blunt trauma or penetrating trauma. But you also, especially in the third trimester, start to worry about shear forces. So we'll talk about those in a minute. Domestic violence is a big source of trauma in pregnant women. So domestic violence incidents can go up as much as 50% in pregnancy or in the first year postpartum. So something you always want to think about when you're seeing a mom that comes in with trauma of an unknown or suspicious cause. You want to think about abuse. And then these pictures just show, let's see if my pointer works here. Oh, I can see it over there, but I can't really see it here. Okay, so this obviously a smaller blunt trauma. This is kind of overall blunt trauma, and you can start to see some of the bruising coming up here. That's likely from the uterus itself. We talked about abuse, and then this is a penetrating trauma, and you can see where it went through the wall of the uterus. So, important to think about the normal physiology changes in pregnancy when you're dealing with any sort of trauma in mom. So some of the normal things that you would look for in terms of vital sign changes, relative blood loss, things like that are going to be different in pregnancy. Mom has an increased blood volume, so she's got a little bit more leeway there before she's going to show signs in her vitals that things might be changing. Okay, so you got to kind of keep that in the back of your head. So this slide depicts when you are evaluating a pregnant woman, especially if you're worried about blood loss, whether it be from pregnancy-related changes, which we'll talk about later, or trauma, you want to make sure that if you're laying mom on her back for evaluation, that you have her tilted, ideally on her left side, okay? So if you see the uterus here is putting pressure right there on mom's vena cava. She eventually is going to become hypotensive, and you're going to get decreased blood flow to the uterus from that compression. If you tilt her 15 degrees or more over to the left, you're going to open that up. So, like we talked about, keeping in mind, mom's already going to have an increased cardiac output, increased blood volume, so she's got a little bit more leeway there in terms of blood loss. Respirations are different. And then you always want to remember that you're taking care of two people. So whenever you have a trauma on mom, part of your FAST scan or part of your initial trauma evaluation needs to be baby as well, especially if we're over the age of viability. So if we are 22 weeks or greater, you need to include baby's heart rate as part of your evaluation, because that's going to give you some information on how baby's doing as well. But the other key thing to remember is if you don't treat mom, by default, you're not treating baby, okay? So in a trauma or emergent situation, you need to stabilize mom and also treat her appropriately as you would basically any other trauma patient, keeping baby in the back of your mind, but not letting baby really prevent you from doing what you need to do for mom. Does that make sense? Sometimes it's hard to balance those two patients. Okay, questions about trauma? Okay, so now we're going to move on to some of the things that are more specific to pregnancy. So those of you that have been on the unit have probably seen at least one mom with a hypertensive disorder of pregnancy, right? Super common. Some days it seems like we're running a blue light special on those. But gestational hypertension is a continuum of disorders that affect pregnant moms. By gestational hypertension, it occurs after 20 weeks gestation, and it's one of the most common complications we see in pregnancy. It is the most common cause of maternal morbidity and maternal mortality. We differentiate gestational hypertension from chronic hypertension. Chronic hypertension is elevated blood pressure that presents prior to 20 weeks of gestation. And gestational hypertension resolves after delivery, but it's not immediate. Okay, it may take up to 6 weeks for complete resolution, and that includes all hypertensive disorders along the continuum. Typically, we look at the measure being 140/90 as abnormal. Other things that we check for or that we find concerning along the hypertensive disorder spectrum is sudden increase in weight gain, swelling, or protein in the urine. These are the two most common medications that we use to acutely treat hypertension in pregnancy, labetalol and hydralazine. I know those are kind of blurry and hard to see. Labetalol is also our most common oral medication that we use. Another oral medication that's used routinely is nifedipine. You cannot use ACE inhibitors or traditional beta blockers, typically in pregnancy, because of complications. Okay, other worrisome signs that you start to look for are illustrated along the bottom here. So sudden increase in swelling, especially pitting edema, headache, or vision changes. Those are signs and symptoms of preeclampsia. So we start with gestational hypertension, which is just an elevation in blood pressure. If you add proteinuria along to that, hypertension plus proteinuria equals preeclampsia. Okay? There's mild and severe preeclampsia. The severe features are listed here for you on the slide. So thrombocytopenia, platelets typically less than 100,000, or a significant reduction from what mom's normal was. Renal insufficiency, a creatinine of 1 is abnormal in a pregnant patient. Okay? Typically you see a serum creatinine decrease in pregnancy. Renal efficiency or creatinine clearance goes up in pregnancy, typically. So if that serum creatinine is going up, mom's kidneys are not working, that's bad. You can see impaired liver function with rise in LFTs, pulmonary edema, or cerebral or visual symptoms. That's the headache and the blurry vision. So some risk factors for preeclampsia, or all gestational disorders of pregnancy you can lump in this group of risk factors. First pregnancy tends to be more common. Advanced maternal age, so mom's age 35 or greater. History of multiple pregnancies with preeclampsia or hypertensive disorders. Chronic hypertension, so if mom was hypertensive at baseline before pregnancy, she has a greatly increased risk of having either worsening hypertension or preeclampsia during her pregnancy. If she has pre-existing renal disease or renal insufficiency. Diabetes, whether it's insulin dependent or not, baseline diabetes increases your risk of blood pressure problems. And then African American race. Okay, so we talked about the what constitutes severe preeclampsia, okay? But the most feared complication of preeclampsia can happen in the absence of any of those severe features, okay? And that is eclampsia. Everybody know what eclampsia is? Seizures, yeah. And so that can happen with mildly elevated blood pressures. It can happen in the absence of any of that other end organ damage, okay? So you always want to have that kind of in the back of your mind as a possibility. Thankfully, it's not very common, but it can be quite severe. We treat it with magnesium sulfate, okay? That's the drug of choice. That's how you treat it acutely. You give mom a 6-gram load, and that's through the IV. In moms with severe features to their preeclampsia, you can prophylax them with magnesium sulfate. That's a continuous infusion. You give it, again, a 6-gram load and then continuous infusion of 2 grams per hour. Okay, questions about preeclampsia, severe preeclampsia, or eclampsia? Okay. There's a subset of severe preeclampsia called HELP syndrome. We've had a couple of patients on the unit recently that have had this. Any of you guys been involved in their care? Yeah? Okay. So HELP stands for hemolysis, elevated liver enzymes, and low platelets. You can have HELP syndrome with 2 of these, but most typically you see all 3 of them together. So mom will present with proteinuria, can be mildly elevated blood pressures, can be severely elevated blood pressures. But the key to it is she'll have hemolysis, so you'll see schistocytes if you look at her blood smear. She'll have an elevated LDH, which tells us that those red blood cells are being hemolyzed. She'll have elevated liver enzymes and then low platelets. And risk of eclampsia is still present with HELP syndrome. HELLP syndrome is extremely dangerous for mom and baby. It's fast progressing. Due to these changes, baby can start to be in distress quickly. So these are the patients that you deliver right away. You don't wait. You don't have time to wait. In extreme cases of HELLP syndrome, you can see this purpura type rash here. And this picture with both mom and baby intubated is showing the severity of this particular subset of the disease. So moms decompensate quickly, babies decompensate quickly. The cure for both is delivery, regardless of gestational age. Questions about that? And this just illustrates that point. So maternal mortality is, depending on your source, 1 to 1.5%. With HELLP syndrome, fetal mortality based on gestational age, anywhere from 10 to 60%. Okay, questions about hypertensive disorders? All right, so let's go. Typically, you see those more commonly towards the end of pregnancy. Let's back it up to the beginning of pregnancy. So threatened abortion. Threatened abortion is defined by bleeding at any time prior to 22 weeks gestation, okay? So prior to 22 weeks gestation, baby is not viable, and so that's where you get the term abortion. In medical terminology, abortion and miscarriage are synonymous. So anytime you have any sort of vaginal bleeding, it can be a threatened miscarriage or threatened abortion. So you want to evaluate. That always includes a pelvic exam. Okay, because mom can have bleeding from other sources. It can be from the vagina itself. It can be from cervicitis. It can be rectal. You want to make sure that it's actually coming from the cervical os. That's how you diagnose if this is a threatened abortion or not. This is just illustrations of 3 different definitions here. So threatening is anytime vaginal bleeding occurs. Inevitable, you've either had rupture of the membranes or you have fetal or placental tissue coming through the cervical os. That one's inevitable. Can't do anything to reverse it. Incomplete is where you've had some products of conception pass, but you may have some still in the uterus. And then this graphic over here to the side kind of gives you some statistics here. About 1 in 5 pregnancies end in miscarriage. So this tells you 15 to 25%. Most people split the difference. 20%, 1 in 5 end in miscarriage. Most of those are prior to 6 to 8 weeks gestation. So if mom's not actively attempting pregnancy or not tracking cycles, she may or may not be even aware that she's pregnant. Risk of miscarriage does go up with age. So again, advanced maternal age 35 or greater, increased risk of miscarriage. After 1 miscarriage, really not a significant increased risk of miscarrying again. After 2, that risk starts to go up, and subsequently from there on. Okay, so again, early on in pregnancy, within the first couple of months, anytime you have vaginal bleeding, one of the things in the back of your mind is this a threatened miscarriage? Second thing in the back of your mind is this an ectopic pregnancy? Ectopic is any pregnancy that's implanted outside of the body of the uterus, okay? Most common site for that is the fallopian tube, which is illustrated in this picture here, but you can get an ectopic pregnancy implanted on the outside of the ovary. It can implant in the tube itself. It can implant in the cornua of the uterus. So do y'all know where that is? Right here where the tube joins the uterus. That's one of the most dangerous sites that it can implant. Or you can have an abdominal pregnancy where it's implanted somewhere out here, okay? I've seen it in the omentum. I've seen one on the spleen. Bad news. But most common site for sure is the tube. Risk factors for this, history of PID. So any history of pelvic infection. Chlamydia is the most common, but gonorrhea, chlamydia, multifactorial PID. The presence of an IUD increases the risk of ectopic pregnancy. So risk of pregnancy with an IUD itself, very, very low. but half of those pregnancies that occur with an IUD in place will be ectopics. So something to keep in the back of your mind. History of surgical adhesions. We see this a lot in women who had ruptured appendix as a young girl, okay? So they had all that inflammation, then they had surgery, they got adhesive disease in there. That can mess with how the fallopian tube functions, risk of ectopic. That's also the pathology, some of the pathology from PID. You have adhesions or scarring in there. History of having your tubes tied, and a prior ectopic. So kind of rule of thumb with ectopics, if the patient is in extreme pain and she has vaginal bleeding, it is an ectopic until you can prove that it's not. The only way you can prove that it's not is with an ultrasound that shows a baby in the uterus, okay? Kind of a caveat to that, you can, very rare, but you can have what's called a heterotopic pregnancy, where you have a baby or fetus in the uterus and also an ectopic. So you had two different eggs ovulate, fertilize, and you have both. Extremely rare. Okay, questions about early pregnancy bleeding, miscarriage or ectopic. Okay, let's move on to late pregnancy bleeding, okay? So bleeding anytime during the pregnancy outside of labor is abnormal. So patient presents with bleeding later in pregnancy, second or third trimester, you start to be concerned about the placenta. Two different things going on there. One is abnormal placentation. Two is placental abruption. So we're going to talk about abnormal placentation first. Most common abnormal form of placentation is a placenta previa. And that is when the placenta implants over the cervical os. Okay? You can have a low-lying placenta, which is within 2 centimeters of the cervical os by ultrasound measurement. You can have a partial placental previa, where the edge of the placenta goes up to the cervical os, partially covers it, or you can have a complete. That's what this is illustrating right here. The entire cervix is covered by the disc of the placenta. Risk factors for this: prior C-section, any other prior uterine surgery, prior abortions or DNC, anything that's caused scarring or irritation inside the uterus, advanced maternal age, and multiparity. Typically we see that with grand multiparity, so 4 pregnancies or more. Ultrasound is how you diagnose this with measurement, like we talked about. A lot of times you can diagnose this in the second trimester when we're doing our normal anatomy ultrasound evaluation between 20 to 22 weeks. You'll notice a placental previa. Repeat the ultrasound 4 to 8 weeks later, and the placenta may have moved away from the cervical os. Okay? So when you diagnose it mid-trimester, you always want to follow that up, because as the uterus grows, depending on where it's implanted on the wall of the uterus grows, it may move it away from the cervix. So here's an ultrasound illustration. So these don't project quite as well, but this is the cervical canal. You see this darker area right here. That's the cervical os, and then you can see the body of the placenta is covering that. Okay? So the main thing to know when you're the clinician taking care of a pregnant woman with a placenta previa is you never, ever, ever do a digital cervical exam. You can look with the speculum, but you do not want to check her cervix. Because if she's dilated, you're going to put your finger right into her placenta, you're going to cause bleeding. Okay? So abnormal placenta, look only, don't touch. There's another picture. You can see the cervical os better on this one. So external cervical os, this is vagina. Internal cervical os, so that's the canal. There's your placental mass. And that's just telling you, you shall not pass. So don't put your finger in there, and the baby can't go through, okay? So obviously a baby can't deliver through a placenta, so you need to do a C-section. Okay, questions about that? So moving on, second or third trimester, bleeding. Usually bleeding with abnormal placentation is going to be painless. Bleeding with pain, you start to think more placental abruption. Placental abruption is defined as early or abnormal separation of the placenta from the uterine wall, okay? And that can be very minor to all the way to complete separation, which is absolutely life-threatening for baby. Risk factors for this, number one is high blood pressure. So hypertensive disorders, preeclampsia. Cigarettes, smoking is a big risk factor for placental abruption. Other drug use, we see it with methamphetamines and cocaine. Cocaine's kind of the typical example used there. Diabetes, infection within the uterus, so chorioamnionitis. Early rupture of membranes, and that's thought to happen by the pressure release. So rupture of membranes early on in pregnancy can get shearing of the placenta. Multiparity, you also see it with multiple gestations. So anything to where the uterus is overly distended. Patients that we can give, methergin and misoprostol are the two most common. And then here's illustrating, you want to look for any lacerations. Obviously, that's a big O cause for bleeding right there. You want to repair that, but remember to look in the vagina, at the cervix also. Just because they don't have a laceration on the outside doesn't mean everything else is nice and clear, okay? And then this is showing you your placenta. Make sure you look here at your maternal side. Should be nice and smooth and congruent, okay? If you see a ratty piece or a divot in it or something that doesn't look quite right, you might have a retained fragment. Okay, any questions for me? Anything you guys have seen and we didn't cover? Yeah?
Could you use TXA for postpartum hemorrhage?
I get that question every time. And I think the answer is yes.
Okay.
It is, the answer is yes, but it's not something we use first line. So typically we use our uterotonics first, okay? So Pitocin, Methergin, Misoprostol. And then we go to exploring the uterus, all right? So whether that's manually or with a curette to make sure we don't have retained fragments. But in severe cases of postpartum hemorrhage, yes, we have used TXA.
Okay.
But not as your first line. It's not quite along the same algorithm that you would use for trauma.
Okay.
You know, we kind of go through those other most common causes first. But yes, you can use it.
So just to piggyback, if that's all we have and we don't have Pitocin, like...
So still do...
Prophylactically, like you said, like you start, trying to treat it before it happens.
Right.
So you hang Pitocin, like, even before the placenta.
So I wouldn't routinely probably use TXA because you don't have Pitocin. And I would still go through your checklist of your causes. So if atony, TXA is not going to be as effective, right?
Yeah.
I'd rather you be using your two hands and doing bimanual massage.
Least invasive to most invasive.
Exactly. Put TXA there in your algorithm, but do your bimanual massage, explore the uterus, make sure you don't have a retained placenta, make sure you've inspected for no lacerations. If you've done all that and you're not getting anywhere, then yeah, TXA.
And nursing can help too, right?
Absolutely. Yeah, for sure. And there's a lot of times where, we'll be doing all of this at the same time. So if I've got a big postpartum hemorrhage, I'm going to have my nurse on top doing massage of the fundus while I've got some sort of retractor in there, looking at the cervix, looking at the vagina. I got my hand inside the uterus. I don't typically use a curette because I have little hands, so I can put my whole hand in. Make sure I don't have any retained fragments. I know y'all are looking at your hands, but make sure I don't have any retained fragments. I don't have any tears, so absolutely use your assistance. What else? Yeah.
Retained placenta, is that surgery to have that removed, or can you go in there and get
Like I said, most of the time I go in and get it.
Okay.
Some people will use what's called a banjo curette. So a curette is just a sharp, curved instrument where you go in and you can kind of shear off anything that's inside the wall of the uterus. The banjo one's about that big. So you're using it in a pregnant uterus. You don't want to use a little instrument because you can put it right through the wall. But most obstetricians will go in manually with their hand. Yeah. Yeah.
I wasn't talking about like actual nurses. I was like the baby nursing can help with.
Oh, I thought you meant like people there. I was like, yeah, absolutely. Yes, the baby nursing is going to help with some natural oxytocin release. That's going to help more long term. Most babies aren't going to. Exactly. So in an urgent, if it's a delayed postpartum hemorrhage, sure, that'll help with some natural oxytocin. But right away in the delivery room, I mean, you're going to have a super cooperative baby to do that. I wouldn't rely on him. Yeah?
I've seen doctors, like, they clamp the cord at 30 seconds, almost right away, 60 seconds on like different occasions. Was there like a reason for that? Is there like preference, what they usually do, or is it just like a case-by-case type of?
Current recommendations for term infants is a 30 to 60 second delay.
Yeah.
So there's no difference
Between
evidence-based between 30 and 60. It kind of depends on, you know, how long it takes to dry them off and suction their nose and mouth. Now, cases where you will see us do it right away most of the time, if baby comes out and is not responsive.
Okay.
Okay, so if we don't have a vigorous baby and I need to get baby over so we can start doing NRP, that algorithm, then I'll clamp it before then.
Yeah, I saw that on an emergency C-section.
Exactly.
Last week.
Yes.
And there was a long, like, I think it was the one where we were in the room together. It was
Super long one?
a really long delivery, and the doctor clamped like almost. I want to say that
Pretty quickly.
it was
probably
definitely
after like 15 seconds.
yeah, like 15 seconds. But then I don't think we cut the cord. The dad didn't cut the cord.
Well, that's
Or
like
I didn't place the second clamp on for at least 20 more seconds after that.
Okay.
Well, I think-
So once you put the first clamp on, it doesn't
yeah.
matter.
Yeah.
So that's where your time delay, what
That's
the
what-
literature
yeah.
says,
Mhm.
is that the best is 30 to 60 seconds. Now, in preterm infants, so prior to 32 weeks gestation, we try to wait a whole minute.
Okay.
And that, again, is evidence-based. You want to get kind of that little bit extra blood flow to baby. Certainly in urgent situations, like your emergency C-section that you had, you're not going to have time because resuscitation is going to trump that.
Yeah.
But if you've got a preterm infant that comes out and it's doing okay, it's vigorous, it's breathing, you know, even crying, you can wait that minute. Yeah.
So I remember reading something about this like 6 months ago, maybe a year ago, I don't know.
So your memory's going to be super
something
good at
about
it.
the pulsating to stop in the.
Right.
So like that, is that when you start pulling it out? Oh, wait, when? Is that before you clamp it?
No, you don't wait for the pulsing to stop.
Okay.
So, no, it's more of a time issue. Yes. So that's more in the lay literature. I don't want to say literature. That's more of a lay thing that patients will come in and say, I want you to wait until the cord stops pulsing. Nah, there's not really any evidence or science to back that up. It's more that 30 to 60 seconds, let baby get that little bit extra blood. But there is theoretical risk to waiting too long or to stripping the cord. So that's another question I get from patients. You know, do you take the blood that's in the cord and strip it towards baby, right? No, because there is a theoretical risk of baby getting too much blood. High iron, that can cause neurologic issues.
One more question. We were taught in one of our classes that we were delivering in the field to like leave a stump of the umbilical cord to get vascular access.
About that much.
Is that what you guys do?
So yeah, so you'll see when we put in a cord clamp on, you're gonna leave about 1 centimeter to 1.5 centimeters, if you need vascular access. Which typically in a hospital setting, you're not gonna use that for vascular access on a term infant, but for you guys with what you're gonna have out in the field, that would absolutely be your easiest access.
And you just leave that?
Well, no, it'll fall off.
Okay, cool.
Forever.
Sorry.
Yeah.
I'm a rookie.
No, it'll kind of shrivel up and fall off within a few days, yeah.
It's like-
So for like access, for like IV access into the umbilical cord, like how do you secure that? How do you like? I mean,
Okay, now I'm an OBGYN, but, so I don't do that, the pediatricians do. But you would thread your catheter into your umbilical vessels, and then you would use more of a permanent suture, so like a silk suture,
Okay.
and you're gonna anchor it to the skin and around your catheter.
Gotcha.
That's as technical as I'm going to get on that one.
That's as technical as I need.
Okay,
You got it.
good. All right, guys, anything else?
That was awesome, thank you.
Okay, thanks.